We are making significant breakthroughs in understanding the biology of pancreatic adenocarcinoma and refining the use of combination chemotherapy. For the community oncologist, it's critical to keep up with new research and understand the options being explored in clinical trials. In this peer exchange discussion, I'm joined by an amazing panel of experts in the field of GI oncology. Together, we're going to provide you with a perspective on the recent advances and what these mean to the care of your patients. I'm Dr. John Marshall, Chief of Hematology and Oncology at MedStar Georgetown University Hospital, a professor of medicine and oncology at Georgetown's Lombardi Comprehensive Cancer Center in Washington, D.C. And I'm joined by, as I said, amazing folks, Dr. Edward Kim, an associate professor of medicine at UC Davis and chair of the UC Davis Pancreatic Cancer Research Incubator in Sacramento, California. Dr. Kim, welcome. Dr. Paul Oberstein, Assistant Director of the Pancreatic Cancer Center at NYU, Langone's Perlmutter Cancer Center in New York, New York. Welcome. Dr. Allyson Ocean, Associate Professor of Clinical Medicine at Weill Cornell Medical College and Medical Oncologist at New York Presbyterian Hospital, Weill Cornell Medical Center, also in New York, New York. Upper East, Lower, I don't even know anymore. Okay, welcome.
Thank you.
And Dr. Shubham Pant, Associate Professor in the Departments of Investigational Cancer Therapeutics and Gastrointestinal Medical Oncology at the MD Anderson Cancer Center in Houston, Texas. Welcome.
Thank you.
Paul, I'm going to pick on you first. So, you know, precision medicine is sort of here to stay. Pancreas cancer, to me, has been kind of a late comer into this space. Give me a sense of today, what's your perspective on who should undergo molecular testing with pancreatic cancer, when, how, that sort of thing. Take it away.
So I would say it's true that we're a late comer to this game. There are very few active regimens that use the molecular testing to guide therapy. But that's going to change. And I think what we've seen when we look at large populations of patients, that there are actionable mutations that we pick up. And the only way we're going to find them is if we keep looking for them. And so certainly in the best settings where we're collecting data, we recommend checking for somatic and germline mutations on almost every patient with pancreatic cancer.
So a piece of blood, send it for germline, a piece of tissue, send it for somatic.
Correct. Something, I don't know if we use names.
Yeah.
So something like foundation medicine analysis, sure, or other kind of complementary analysis.
Well, let's talk about that. So, you know, Shub, this is one of the biggest problems I have with pancreas cancer is getting enough tissue for testing, right? Particularly with local tumors and FNAs and EUSs. You know, whether if you guys do your own testing, I think.
Yes.
But more and more we partner with external folks to do these broader profiles. So how critical is it? How much risk do I put that patient at to get enough tissue to do broad molecular testing?
Yeah, so it's you know, the molecular testing is exactly as Paul said, is here to stay. The issue in pancreatic cancer is you really don't know who to test. So do you test the one who's got 10 liver lesions? Do you test the one who has lung-only metastases? There's really no data to guide you. Do you test the one who got 2 months of FOLFIRINOX and progressed, or do you test the one who got 8 months of FOLFIRINOX and did not progress? So it's kind of all over the place. It's really muddy. So it's hard to find somebody whom you look at and say, you know what, this guy's got, you know, lung-only mets, and I definitely should test this because they could come up with KRAS mutations also. The issues in pancreatic cancer is, as we all know, is about 90% have KRAS mutations, you know, 12 DVR being the most common. So, you know, overwhelmingly we see these mutations come up. But however, in the targeted therapy realm, I think about 20% to 25% can have targetable mutations. So you can have MSI-high, 1%, you can have FGFR, some fusions.
Wait, I'm making sure I hear it. So Paul's saying we should test everybody, right? I think. Did I hear that?
I'm saying we should test everybody and share that information.
And share. Well, now we're sharing. Okay.
This is important.
But so
we don't know.
You're talking about subsets of patients. Are you testing everybody? Or you're not testing everybody.
I think you know, I agree with Paul there. So unless you test them, you won't know. So I think we really should. Right now, we don't have data enough to know whom to test. So I think germline, definitely we should be testing everybody. It's also in the NCCN guidelines. You know, when they come up, we should test for germline testing. For somatic testing.
Allyson, why are we doing that? Why are we doing germline testing on everybody for BRCA?
Because we didn't used to do it.
Yeah.
And
it's new, right?
Right. It's definitely new now. And we now have data that shows that if we can uncover a targetable mutation in this disease, it can lead to clinical trials. So will improve clinical trial enrollment, as well as data that just came out today regarding the BRCA mutation and uncovering that mutation and having a therapeutic intervention because of that.
Absolutely. We're going to drill down on that in detail, of course, but yeah.
So I think it's an important point that the reason for one of the reasons for the change is that there is the potential to miss cases where if you go just on historical use of family history, there's evidence now that you will miss a significant portion of patients.
And the more we look, the more we're finding, right? We're overturning a lot of our HPI and family history to actually find these folks. Back to you, though, Ed, on that. You know, a lot of times we're doing testing, not so much in germline, but somatic, and finding funky BRCA mutations. And so are they all created equal, or are some different than others?
We don't know. I think that we're just getting information about the germline mutations, and we needing to see whether this holds up for somatic as well. I think the germline testing is most robust at this point, but there's still a lot of explanation that needs to be done.